Welcome to another episode of AtheroVoice, the official podcast of the Hellenic Atherosclerosis Society. I'm Fotios Barkas, Assistant Professor of Internal Medicine at the Faculty of Medicine of the University of Ioannina, board member of the Society, and coordinator of AtheroVoice. Today, we have the pleasure of hosting Dr. Konstantinos Koskinas, a leading expert in interventional and preventive cardiology, senior physician at the University Hospital of Bern, member of the European Association of Preventive Cardiology Board, and a recognized authority in cardiovascular pathophysiology and risk prevention, as he has recently been one of the leading authors of the focused update on the European Atherosclerosis Society and European Society of Cardiology dyslipidemia management guidelines. During this year's 11th Pan-Hellenic Congress of the Working Groups of our Society, Professor Koskinas joined us to discuss a fascinating and rapidly evolving area in cardiovascular science, Crosstalk Between Adipose Tissue and the Cardiovascular System. So, Professor Koskinas, welcome to AtheroVoice. It's an honor to have you with us today.
Thank you very much for the invitation. I'm very happy to be here today, and I'm happy to discuss these important issues.
Let's begin with the fundamentals. We increasingly understand that the cardiovascular risk is driven not just by how much adipose tissue a person carries, but by what kind of adipose tissue they have. Its inflammatory state, its metabolic profile, and its anatomic location. So, how should clinicians think about good versus bad adipose tissue phenotypes? And does this change how we evaluate obesity-related cardiovascular risk beyond body mass index alone?
These are great questions, Foti. I think we should try to take a step back and first of all try to increase awareness about obesity as a modifiable risk factor, and also raise awareness for the fact that there are treatments currently that can manage effectively these risk factor. If we want to speak on clinical terms, I think it's important to also help our colleagues understand that measurement of obesity or overweight is something that needs to become part of their everyday clinical practice. So the very first thing that should happen, it sounds self-explanatory, but it's unfortunately not, as it seems, is to, again, address obesity in everyday practice. Measure weight, measure BMI. Beyond that, as you very correctly pointed, there are so many other factors that are associated with the risk that is carried by the presence or absence of obesity. Beyond BMI, we should also try to look at the phenotype of our patients, of our individual patients, and, for example, search for the presence or absence of visceral adiposity or abdominal adiposity, as opposed to only overweight or obesity based on BMI. There are, of course, many other means of addressing or assessing obesity or adiposity, including, for example, imaging or other sophisticated techniques. I think, though, that on a clinical level, it's important to establish the importance of recognizing the presence of obesity and then, at the very least, also assessing the presence of abdominal obesity by very simple clinical anthropometric measures.
Adipose tissue communicates with the cardiovascular system through multiple pathways, systemic endocrine signaling and very local paracrine effects. Which of these pathways appears most relevant for vascular disease development, and how does anatomical proximity of certain fat depots amplify their biological impact?
Yes, the more that we're understanding the pathophysiology and the interplay between obesity and the cardiovascular system, the more we understand that there are so many pathways involved in these processes. I don't think that the current evidence allows us to put a specific weight on either endocrine, paracrine, or local or systemic factors. It's rather a multifactorial process. We are now beginning to better understand those processes, to identify mechanisms that are underlying the impact of obesity on the cardiovascular disease and cardiovascular risk. So simply put, I would say that it is probably a combination of both local and systemic effects. We are in the process of identifying also some specific molecules that can be targeted, some signals, some signs that can be used as therapeutic targets, but I think we're a bit away from having them as part of everyday clinical practice. Nonetheless, I think that our understanding is growing and we can be very optimistic about the future in this field.
Perivascular adipose tissue is now seen as an active regulator of vascular biology. So it can modulate vasodilation, oxidative stress, and inflammatory activation. In health, it can be protective, while in cardiometabolic disease it becomes pro-inflammatory and pro-therogenic. My main question will be then, what makes this kind of tissue, the perivascular adipose tissue, such a pivotal player in vascular homeostasis, and how does its phenotypic shift contribute to atherosclerosis?
That's also a very important topic for this. We know that for many years, perivascular adipose tissue was seen as simply a structure that would support the vessels, but currently we know that it is much more than that. As you correctly pointed, it produces so many active molecules that can affect the function of the cardiovascular system, either the vessels or the heart itself. It is true that at the beginning stages of either obesity, pre-adiposity, some of the molecules that are secreted by perivascular tissue can actually be protective. There is, however, imbalance. For example, in conditions such as insulin resistance, prediabetes or diabetes, then there's a shift of this secretome of this location of tissue, and it becomes a more either pro-atherogenic or pro-inflammatory.
On the other hand, there is epicardial fat, which interacts directly with both the coronary arteries and the myocardium. Its role spans from metabolic support to arrhythmiogenesis, atrial fibrosis, and modulation of coronary inflammation. So what does epicardial adipose tissue contribute to coronary artery disease and atrial fibrillation, and which mechanisms appear most clinically relevant today?
That's also a great topic that is also the focus of intensive research over the last years, and we have had some great studies highlighting the role of epicardial tissue, not only its presence, its volume, its mass, but also its metabolic activity, and more specifically the presence of inflammation. We know that we can actually measure it in vivo. There is imaging techniques that allows us not only to assess the presence, identify the presence of this localization of adipose tissue, but also measure it, quantify it, and again measure its activity. I think that it is becoming more and more relevant, and the likelihood that it will also become clinically relevant is, I think, quite high.
So let's get to the so-called adipose tissue secretome. You know that adipose tissue secretes a wide spectrum of bioactive mediators, adipokines, microRNAs, and gasotransmitters, all of which play a role in vascular inflammation, plaque development, and metabolic regulation. So which components of the adipose secretome look most promising as a biomarker, or maybe as a therapeutic target for cardiovascular disease prevention?
So as you also mentioned, Foti, it is multifactorial, but I think that where the field is moving is probably the field of inflammation that is triggered by the presence of fat in the epicardial tissue or even in the perivascular tissue. And we know which molecules are involved in these processes. And currently also looking more broadly, we know that we have also drugs, so pharmacological issues that can suppress inflammation. I think that there are two areas where the research might probably focus in the next years. The one is to even better refine the use of localizing the presence and also the activity of fat around the heart, and also trying to suppress inflammation in these localizations by the drugs that are either currently available or under development. I think that more broadly speaking, as I said, we do have drugs which we know can suppress inflammation also in the adipose tissue. One key question nowadays is how to use these drugs and which patients are more likely to benefit from these treatments. So I think that the key question, the key challenge will be to, again, identify the phenotype of our patients and identify those who are more likely to benefit from these new treatments.
And now we are coming to the end of this great discussion. Given the complexity of the adipose cardiovascular crosstalk, inflammation, oxidative stress, lipid handling, and metabolic signaling, the question is, how close are we to translating this knowledge clinically? So my final question will be, what do you consider the most realistic therapeutic possibilities in the near future? You talked about the pharmacological modulation of adipose inflammation, but what about the imaging-guided therapy, metabolic interventions, or something else entirely?
I think that's a great point. I think that there has been much progress in the last year, specifically in the field of identifying inflammation in the epicardial adipose tissue. We know that there's pioneering work, for example, by Harris and Riadis in this field. I think that is becoming really close to becoming one of the tools that we'll probably be using in our clinical practice in the future. This is my personal impression.
Professor Koskinas, thank you for this outstanding, insightful discussion. Your explanation highlight how adipose tissue is not merely a metabolic organ, but also a powerful regulator of cardiovascular health, opening new avenues for prevention, diagnosis, and treatment. Thank you for being here with us with the podcast and, of course, of joining the 11th Pan-Hellenic Congress of our society here in Athens today.
Thank you very much. It was a pleasure.
And of course, to everyone listening, thank you for joining us on AtheroVoice. Stay tuned for our next episodes, where we'll continue to explore cutting-edge topics in cardiovascular prevention and, of course, translational research.